introduce you.
Yeah.
So, first talk is by Dr. Samvedya Veenish. She finished her oculoplasty fellowship from Giridharai Hospital. She is a budding oculoplasty surgeon going to practice in and around Kannur. All the best, Samvedya. And her topic is on anatomy of an aging face.
Thank you, Dr. Shebin. So my topic is on anatomy of aging face. So we know a person's face can give us a lot of information regarding the age, gender, emotional state. And for aging, there are a lot of invasive and non-invasive procedures to reduce the signs of aging, which is based on the anatomy of the face. So the anatomy of the face in a traditional approach can be divided into thirds, and in functional approach it can be divided into anterior face and lateral face, which is by a vertical division, which corresponds to the facial retaining ligaments. These ligaments function is to bind all 5 layers, and they form the cutaneous grooves as a person age. There are 5 layers basically: the skin, which has an epidermis, which is a cell-rich layer, and dermis, which is highly vascular, and its thickness varies based on the function. That is, it is thinner in more mobile areas such as eyelids. And the next layer is the subcutaneous tissue, which consists of subcutaneous fat and fibrous retinacular cutis, and it is highly compacted in mobile areas such as eyelids and lips, and it's thick in nasolabial folds. The third layer is the musculoponeurotic layer. It has different names in the different regions of the face, such as it is called as gallia in the scalp. In the periorbital region, it is called the orbicularis fascia, smash over the mid and lower face. And there are superficial muscles and deep muscles. The fourth layer is the loose areolar tissue, which contains soft tissue spaces retaining ligaments, deep part of intrinsic muscles, and facial nerve branches. The facial spaces are bounded by the retaining ligaments, and they are potential and anatomically safe spaces for blunt dissection. So there are different names for the spaces regarding the different regions of the face. The fifth layer is the periosteum. So there are certain facial danger zones which contains the branches of the facial nerve. So one should be very careful while you do procedures around these regions. Now, the aging changes of the face is basically an interplay of changes occurring in all these 5 layers. So how to diagnose? The skin changes are readily visible, and the bony changes are measured by imaging, whereas the other layers are not easily visualized. So the skin changes are based on the genetics, environmental exposure, hormonal changes. So basically the skin gets very thinned out and flattened because of dermis atrophy, resulting in loss of elasticity and architectural regularity. In the subcutaneous tissue, you see fat descent, selective atrophy, and hypertrophy of the retaining ligaments. So there is a loss of smooth transition over the face. So as a result, you can see as you age, there is more fat loss in the upper part of the face compared to the lower part of the face. The expression lines and wrinkles are as a result of contraction of the mimetic muscles. This happens in dynamic movements in young patients, whereas this lines becomes permanent while you age. Muscle aging, the mimetic muscles of the face does not have same degree of degeneration as compared to the other skeletal muscles. It is noted that orbicularis oculi often remains histologically unchanged while you age. There is a decrease in strength and increase in laxity of the retaining ligaments, which causes the facial spaces to expand, resulting in jowl formation in the pre-masseter spaces, and in pre-zygomatic space you can see malar mounds and bands. The facial skeleton undergoes significant resorption, which results in inferior and medial repositioning of fat pads and muscles. So what happens is the triangle of youth gets inverted as you age. Region-wise, in upper third of the face, the forehead and glabella shows wrinkles, increase in nasofrontal angle. And in the temporal region, you see a decrease in bitemporal width, giving a scalloped appearance. In the eyebrow, you can have either brow ptosis or brow elevation. And coming to the middle third of the face, periorbital area, there is increase in orbital aperture, loss of lateral canthal tilt, globe protrusion resulting in senile and ophthalmos. So in the upper eyelid, there could be elongation of the lid length, loss of alignment of eyelid fold. There could be increase in pretarsal region, levator dehiscence, and resulting in ptosis. As you can see, there is left eye ptosis. And there could be change in the upper eyelid arc, resulting in a typical A-frame deformity. In the lower eyelid, as described by Dr. Milind in his recent article, the hills and valleys. So the valleys and hills becomes more prominent as you age. So valleys are tear trough, eyelid crease hollow, zygomatic hollow. Tear trough is nothing but a depression lateral to the anterior lacrimal crest, which is unlimited by the inferior orbital rim. The tear trough is called as orbital rim hollow in elderly patients. So it is orbital rim hollow corresponds to orbital malar ligament. The zygomatic hollow corresponds to zygomatico-malar ligament, and eyelid crease hollow corresponds to insertion of the lower lid retractors to the dermis. Between the zygomatico-malar ligament and orbitomalar ligament, you see the malar mounds. The hills you see is the orbicularis roll, orbit fat bag, then fluid bag, triangular malar mold. And the orbicularis roll and the prolapse orbital fat is separated by the eyelid crease hollow. The orbital fat bag and fluid bag looks almost similar, but you can differentiate, such as like fat bags are more compartmentalized by the inferior oblique tendon, whereas fluid bag has a smooth contour. As you can see in the picture, fat bag disappears on looking down and is more prominent while looking up, whereas fluid bag almost remains the same. So malar mouse almost forms a festoon as you age. Though these changes are basically because of the soft tissue thickness difference, which is thin above and thicker below, natural posterior incline of the mid-cheek, and significant retrusion due to resorption of the maxilla. So in the lower face, most common changes seen are jowl and labiomandibular fold, which is because of the weakening of the facial retinal ligaments and inferior displacement of the buccal fat. So these are the changes in a glance and my references. Thank you.